Case 2 is a patient that presents with a nosebleed. A 25-year-old previously healthy woman comes to the local emergency department with epistaxis for several hours that has finally responded to pressure and elevation. The patient was bleeding from both nostrils. She denies fevers, chills, or recent upper respiratory symptoms. She had noted multiple spots on both ankles, and she has gingival bleeding. So evidence of bleeding and epistaxis, multiple spots on the ankles, purpura is what she's likely talking about, and gingival bleeding. And just right away, when you hear about this history, it should give you a clue to what type of bleeding we're talking about. So, for example, if people have a factor deficiency, usually the bleeding is real serious. You don't really get only purpura, you don't get epistaxis, you really get deep bleeding. Patients that get platelet deficiencies or platelet qualitative problems usually present with the purpura, with the superficial bleeding and things like that. So right away when you hear a history like this, you not only do you know that it's some kind of bleeding diathesis, but that the patient, you likely know the system involved, and likely from this patient's history, it's pretty much that the platelets are deficient or there's a quality problems with the platelets, but we have to make sure. We have to make sure, of course. The complete blood count was drawn, which revealed a platelet count of 10,000. So definitely low platelets. The normal is 150,000 or above. The patient is not on any medication, and she has no past history. So right away you know that the likely problem is the platelet count. But we don't get is that if she has any other deficiencies in the rest of the complete blood count. So just them telling you just the platelets are low, well, that could be just, you know, a specific problem with the platelets. Or it could be a more generalized problem with the bone marrow. So, for example, if the red cells are low, and the white cells are low, and the platelets are low too, this is a bone marrow problem, and you start to think about things about like aplastic anemia, things like infiltrative diseases of the bone marrow, like acute leukemias. But we don't have any information on that. We assume that if they didn't tell us, it's probably normal, but you have to make sure that this is the case. What we know is that at least a bleeding diathesis in this patient is going to be due to the low platelet count. So the vital signs in this patient, the patient is febrile, the blood pressure 110/86, the pulse 88 per minute. The physical examination shows no focal lesions in the nasal mucosa. It's always important to examine where the patient's bleeding from, because sometimes you could find a focal lesion. It's interesting that some patients have a bleeding diathesis, but they bleed in areas where there's lesions. Oropharynx is not infected. Multiple petechiae is seen in both ankles, so it's likely that this patient has some kind of purpuric lesions. The remainder of the exam is unremarkable. So, well, what's our differential diagnosis? Well, if this is only a isolated problem with the platelets, then you have to think about immune thrombocytopenic purpura. ITP, immune thrombocytopenic purpura, is an isolated problem with the platelets where there's antibodies produced against the platelets. And in the adult version, the most common scenario is that they click onto the platelet surface, and then these platelets are cleared by the spleen and other reticuloendothelial organs. In the children's form, which is more benign and more short-lived, these platelets directly lyse the platelets. These antibodies directly lyse the platelets. So it's a little bit different in the adult form and the children's form, but the bottom line is that there's antibodies against the platelets in both scenarios. The children's form usually occurs after some kind of viral syndrome, a couple of weeks after viral syndromes where these antibodies are generated against the platelets. So if that complete blood count is normal otherwise, other than the platelets, I would think about ITP as my first diagnosis. A couple of other things you have to think about is acute leukemia. Acute leukemia and aplastic anemia would present exactly the same way. But now from the complete blood count, we would have evidence of pancytopenia in this patient. And we didn't hear anything about that, but we have to verify that from the CBC. Make sure you don't assume something unless you see it yourself. A disseminated intravascular coagulation is a consumptive coagulopathy. Platelets are consumed, factors are consumed. These patients have severe, very, very dangerous bleeding, and it's usually associated with some type of other event, especially some kind of infection, especially gram-negative infections. So we don't have any history of anything like that, and from what we got from the physical exam and from the history, the patient mostly has superficial bleeding. So I definitely would think about less of this than ITP or the other syndromes. Drug-related thrombocytopenia is a possibility. This is pretty common. Whether it does it through autoimmune nature or direct suppression in the bone marrow or direct lysis, there are many drugs that do this. Alcohol may also do it as a direct effect on the marrow, but we have no history that the patient has taken any type of medication. Von Willebrand's disease is a platelet qualitative issue. So there's enough platelets in the body, but they don't have von Willebrand factor in order to kind of clump together and cause hemostasis. So this patient tends to bleed more, especially after surgical procedures. But in patients with von Willebrand's disease, the platelet count is normal. The platelet count is always normal. There's a qualitative problem with the platelets. They don't clump together well. That's the defect. But the count of the platelets is normal. In fact, the only thing that is abnormal in von Willebrand's disease is the bleeding time. The bleeding time is elevated despite having normal platelets, and the PTT is a little bit elevated because von Willebrand factor is a carrier protein for factor 8, procoagulant factor 8. So if you don't have von Willebrand factors, your factor 8 is also affected. So that the PTT is a little bit elevated in this scenario, but the platelet count is always normal. So I'm not going to think of von Willebrand's disease in this patient, especially because patients with von Willebrand's disease have a long history of bleeding, right? This patient didn't. Marrow infiltration from malignancy is a possibility, but this is a patient is fairly young. So to think about bone marrow infiltration, like multiple myeloma, like things like that, metastatic disease, is less likely. I would think more in this patient, marrow infiltration from acute leukemia or aplastic anemia, which we talked about here. That would be a possibility. And then in that case, you would see all 3 cell lines down, right? Pancytopenia. SLE with immune thrombocytopenia is part of ITP. When we diagnose ITP, we put SLE here to remind everybody that ITP occurs after some kind of viral syndrome out of the blue, de novo, with no predisposing condition, but sometimes occurs as part of collagen vascular diseases, especially lupus. It can occur sometimes with cancers, with neoplasias, like chronic lymphocytic anemia, and can occur with HIV patients. So please remember that. So right here, I would think of ITP first, by far, and then I would think about acute leukemia and aplastic anemia if I saw other deficiencies on the bone marrow. So where do we go from here? Well, we want to take a look at the complete blood count. We want to look at the ProTime, right, and the PTT to make sure this is not DIC or some other kind of bleeding diathesis. We want to look at fibrinogen, right? This is abnormal in DIC, and then we want to look at some other tests. But let's start from here. The complete blood count, the white cell count, is normal. That's very important. You don't want to see that elevated or low, because that would point to an acute leukemia. Remember, acute leukemia can present with very high numbers of white cells, but it could also present with low numbers of white cells, right? And this is called a leukemic leukemia. Hemoglobin is normal, very good. I want to see that. And then no abnormal cells are seen, which is very important. No blasts are seen, and platelets are just decreased. So an isolated platelet problem, the pro time is normal, 11 seconds is normal, and people with the pro time now measure the INR, International Normalized Ratio. That's a way to standardize your pro time, right? So an INR of 1 or less is always normal. It standardizes because different labs use different pro times, so you want to look at the INR. If it's 1 or less, it's normal. A PTT of 33 seconds is normal also. A fibrinogen of 400 is normal, so the fibrinogen is not consumed as it would be in consumptive coagulopathy syndromes. And then, just to be on the safe side, if you wanted to confirm this diagnosis and rule out rare forms of leukemias and stuff like that, you would do a bone marrow biopsy and aspirate. You would look for anti-nuclear antibodies just to make sure this patient doesn't have lupus as a cause of the ITP now, right? So they may ask the question differently here. They say, okay, you've diagnosed ITP. What do you have to do further? And the answer is I have to look for diseases that are associated with ITP. As I said to you, it may occur just out of the blue, but it can occur with lupus. It can occur with HIV. And that's why they're getting HIV here. And it may sometimes occur with things like CLL, but this patient is too young to have CLL. These guys also got antiplatelet antibodies. They wanted to make sure that this patient had the disease that we're talking about, and they even got an abdominal ultrasound to make sure there's nothing there. So a bone marrow biopsy shows normal cellular, normal erythroid and myeloid maturation, a marked increased numbers of megakaryocytes. So that is pathognomonic for ITP. If you have a healthy marrow, you produce megakaryocytes, and you got a lot of megakaryocytes, and you put out from your marrow these large platelets. That's why these patients don't bleed a lot, because they have good functional platelets. The anti-nuclear antibodies are negative. The HIV is negative. The antiplatelet antibodies are positive, is what you expected here to make sure the diagnosis is correct. And the abdominal ultrasound, you want to take a look at the liver, the spleen, and the gallbladder. All seems pretty normal here. So what should be our treatment plan for this patient? So a couple of things. The number one drug, the drug of choice to treat ITP in patients that have bleeding, that have active bleeding. This patient has maybe mild bleeding, but it's still bleeding. The drug of choice are the corticosteroids. And the drug of choice is either prednisone orally or dexamethasone, and usually 4 to 6 weeks, followed by a gradual taper. Now, I say gradual taper because I told you that adult cases of ITP are more resistant. And this taper may be 4 to 6 weeks, maybe 3-4 months, because as you taper off, the platelet count sometimes starts to come down, and then you have to go up on the prednisone. In fact, some cases are very refractory cases, and then you have to keep them on corticosteroids for a very long time and consider doing more chronic treatment like splenectomy and so forth. But for the acute setting, the number one treatment in this patient would be corticosteroids. Prednisone is probably the best drug to use in this case. Now, what if the patient is not bleeding? What if the patient is not bleeding? Then the answer is, if the platelet count is 50,000 or above, most people would not use any type of treatment in this patient and would just watch the patient. So it happens that sometimes we find out about ITP just because we check somebody's blood, and the patient's platelets are 60, 70,000, but the patient has no bleeding. And what I just said is, in those cases, unless the platelet goes down, the platelet count goes down below 50,000, you probably could watch and wait and monitor the patient without giving them any steroids. The reason why the patients with 50,000 or above are not really at risk for bleeding is because these are very functional platelets. Remember, I told you that The patient with ITP has a healthy marrow. They have megakaryocytes. They increase their megakaryocytes. They produce these large platelets in the periphery that are very good in terms of hemostasis. So these patients really don't have a risk for bleeding. Some people will even watch patients with lower than 50,000 platelets, and some of them close to 40,000 won't bleed. But for your purpose, anybody less than 50,000 or bleeding you got to use prednisone. Above 50,000, 50,000 and above, you're okay to watch and wait. When do we use IV gamma globulin, immune globulin? If you have severe bleeding, and you need a quick increase in the platelet counts, you give them prednisone at the same time. This is the acute setting, and you give them immune globulin. RhoGAM has also been used here. So please remember that if they don't give you, and you really need to increase the platelet count really quick, if they don't give you immune globulin or some kind of immune globulin, then think about giving them RhoGAM or like I said, immune globulin. So please remember that. If the patient has chronic disease where you can't taper the steroids down, or recurrent disease, you taper the steroids off and then 1 year later the patient's again with bleeding and low platelet count, then you think of splenectomy. It's very important because I described to you a little bit of what ITP is all about in the adults. Not in children. Children is a very self-limited form of ITP. In adults, it's more chronic because the platelets are destroyed by not direct destruction by the antibodies, but these antibodies click onto the surface of the platelets and are removed by the spleen, and these tend to be more chronic antibodies. But the important thing is that they're removed by the spleen. So if I do a splenectomy, then this works. Some people are treating these patients in certain severe cases using cytotoxic drugs and danazol and stuff like that. They're not going to ask you about stuff like this, but it's good to know in the back of your mind that there are other treatments for chronic and resistant cases. Number 5 is a very important issue, and let me explain to you. They've asked a question about this. Generally, we don't want to use platelet transfusion in ITP. The reason is because if you give them the platelet transfusion, it's eaten up. It's eaten up in the periphery, right? So it's useless. It's not contraindicated. There are diseases like TTP where platelet transfusion is contraindicated. ITP it's not a contraindication in ITP to transfuse platelets. It's basically useless. So it would be less helpful. That's the answer. Is if they ask you what's less helpful in this case, ITP, the answer is platelet transfusions don't work. But what if the patient is having a severe life-threatening bleed? Then in that case, the only way that you could try to stop the bleeding, you give them prednisone, you give them immune globulin and all that stuff, but you give them platelet transfusion. You know they're going to get eaten up in the periphery, but what you're really trying to do is stop the bleeding really quick so the patient doesn't die. So platelet transfusion is only to be used for severe, life-threatening, unresponsive bleeding. So please remember that. This is very rare in ITP. The reason is because people with ITP generally have very healthy platelets. You'll notice in ITP people with 10,000, 15,000, 20,000 platelets, and they hardly bleed. So please remember that. Only in that case, and please know what we used each thing for. Steroids in the acute setting, immune globulin for severe bleeding, but not only life-threatening but severe bleeding. Splenectomy for chronic cases, and platelet transfusion for severe, life-threatening. The patient's going to die bleeding. That's when you need to transfuse platelets. So let's do a case review here. We've talked a little bit about these diseases. Von Willebrand's disease is a platelet-type bleeding because I told you these patients have a qualitative problem with their platelets, but their platelet count is normal. They just don't clump well together because they don't have von Willebrand factor. if you want to diagnose Willebrand's disease, you could do all these very, very high-cost tests and stuff like that, complicated tests, but really just measure bleeding time. An elevated bleeding time with a normal platelet count, it's only von Willebrand disease for our purpose. The PTT is also a little bit elevated. Please be careful of that. Please be careful that it's a little bit elevated. They try to give us von Willebrand's disease on the boards and stump us by telling us that the PTT is elevated. Please remember that, because they want to make you think that this patient has some kind of factor deficiency. They don't. It's not the case. Ristocetin assay measures effective platelets, how well the platelets clump. So the ristocetin assay is abnormal in patients with von Willebrand's disease because they don't clump together well. How do you treat them? The answer is not factor VIII replacement. It doesn't really not needed, only rare cases. It's DDAVP, vasopressin. DDAVP, a form of vasopressin. The DDAVP is what we also use in central diabetes insipidus, and it's used intranasally, and it works very well a couple times a day. Intranasally a couple times a day. It secretes von Willebrand factor VIII. It secretes procoagulant factor A2. So DDAVP is also used in some mild cases of hemophilia A, because factor VIII is missing. So I told you it secretes a little bit of factor VIII, good enough to stop the bleeding in the mild cases of hemophilia. ITP, what this patient had, epistaxis, petechiae purpura, and plus GI CNS bleeding, but I told you, for your purpose, this is very rare because the platelets are very functional, so you usually see more superficial bleeding in patients with ITP. The pathognomonic finding in these patients is you have a normal CBC except an isolated low platelet count. You find positive antiplatelet antibodies in the periphery and increased megakaryocytes on the bone marrow. That's the definition of ITP, that you have peripheral destruction of platelets by antibodies. And what does your bone marrow do? It puts out these large platelets because it produces a lot of megakaryocytes. You can't see megakaryocytes in the periphery. Very difficult to see because they're kind of big, but you see the large platelets in the periphery. Treat with steroids or IVIG or ROGAM if severe bleeding, and I told you think about splenectomy in very resistant cases, chronic cases. DIC has both platelet and clotting factor type bleeding because you consume platelets, you consume clotting factors. Usually it's in the face of other major disease, especially sepsis syndromes. We see it with either sepsis syndromes or gynecologic catastrophes like amniotic fluid embolization and stuff like that. In this case, the PT and the PTT would be elevated. That's why we got it, just to make sure we ruled out this stuff. The platelets would be low. The D-dimer is produced, right, because of all the consumption. There's elevated fibrin split products and low fibrinogen levels. Remember, we measured fibrinogen in this patient and it was normal. Really, the treatment is, you don't know what to do in DIC. Really, the most effective treatment is treat the primary disease. Some people use fresh frozen plasma if the patient is bleeding, plus sometimes platelet transfusion, but it's really not effective. Really, what you need to do is treat the primary disease. Bone marrow infiltration, either by acute leukemia or cancer, or sometimes infiltration by fat cells, like in aplastic anemia. There's other systemic signs of disease are present, sometimes severe anemia, other infectious processes and stuff like that because the white cell count is low. Remember, all three cell lines are decreased, and of course the bone marrow biopsy is confirmatory, looking for the blast cells or the fat cells or the malignant cells in the bone marrow. That concludes case 2.